We have another exciting and academic case for you today involving a calcified lesion. You'll understand all sorts of management strategies, but most importantly, I wanted to remind you that you now have the availability of CME. Simple, straightforward, tick mark kind of a questions to answer will take you no more than 60 seconds and you can get 1.5 hours of CME. Please remember that to get the CMEs, you do not need to answer Dr. Sharma's questions at the end of the program. So let that not cause any stress for you. The questions are straightforward, which is feedback on the review. With these introductory words, let me take you to the cath lab where Dr. Sharma and Dr. Kinney are standing by. Samin, good morning. Did we summarize the CME requirements correctly?
Absolutely. And then, as you said, that we don't need them to answer the question, but we want them to present during this CME session. And questions are always good, and many of them will make it to the board review. Those who will be taking the International Cardiology Board at in America. But yes, the key is we want more. This was the first time experiment last time. About 40 people signed up. But I thought this will be at least 400 because the CME is so big. But let's see, it was the first one. And today now has been shown that very simple way, just have to answer a few questions and then you get your 1.5 hours of CME. Just imagine, this is just now for the CC life. We can extend to our structural, our endovascular. So we know that everyone needs 40 CMEs per year. And then, of course, we have our June symposium, we have our December valve symposium, then endovascular symposium in September, and then, of course, top 10. So many of activities we do, you do need not to go anywhere else prepare to get the CME.
Clarification, CME at the moment is only available for the live case. Is it available for the archived yet?
Yeah, very good point. So what we did is we wanted to, because we know the total archives per month still remain 18 to 20,000. So what we need to do basically is to increase more live audience. I know a lot of globally people, participants get in and they ask various questions, and so we want to increase that number. So it is only for live, and we'll see. Maybe it will be a more demand to do the once archived, but right now live, and after half or 1 hour of the completion of the session, that link will disappear. So then you will not be able to get the CME after that. So therefore, yes, it's all live, and it disappears after about 1.5 hour plus of the basically once you have completed the live webcast. And with that
just,
note,
just for the audience, I want them to understand that we have taken great pains to make it seamless. So it's very quick answers, and I hope you can all avail of it.
Absolutely. So this is what a lot of people wanted. I mean, this, remember, this is extra cost to the program, but and extra effort, particularly because anything we do, they're now reviewed by the CME. The CME guidelines are a little different and we are following all the guidelines. So we always had been, and but yes, we are very happy that we are able to offer this CME at present for the live cases, and maybe later on we can think about the archives. So with that note, myself and Dr. Kinney, our usual two operators will be starting along with fellows, Maria Eleni and Jason. And then the nurses will Will and Ashley, and tech is the Asif and Habib, and imaging is our Kiski. So with that note, let's start with the case presentation. We are talking about the target audience. This already has been shown, and we go through the our supporters and so. So this is the case number 185. Little different than what we announced, but similar the theme, that distal left main. So we actually felt this case was a little much better than the distal, that case of the distal calcific left main, similar to what we announced earlier. That is, this is the 74-year-old patient with a new onset class 3 angina and has a negative stress test because of symptoms, had a CTA positive with a positive ctFFR. and basically had controlled diabetes, hypertension, hyperlipidemia. Patient is BMI, as you can see, 36, and A1C, LDL, and CRP are shown. They are all good, well controlled, multiple medical therapy as can be shown here. And then this patient has a cath done earlier of this month, revealing distal left main bifurcation lesion. And Anu can show that, and then we'll come back to what the plan was in this particular case. Right coronary has a moderate distal disease and AV continuation, and that's where we are now, and we are getting ready. That LV was normal. Yeah, good.
Cannot hear
So
Dr.
positive.
Kinney.
So they cannot hear
Yeah.
Dr. Keeney.
No, it's perfect now, Anu.
Good.
Please
Okay.
proceed.
Yeah.
Yeah, so you see the distal left main,
Yes,
ostial
we see
LAD and
clearly.
ostial circumflex,
Right.
caudal view. This is without any dye to
Show
show,
the calcification.
yeah, at that level. And you'll see a better appreciation of the distal left main and ostial LAD.
Yeah, looks like angiographically more lesion is in the circumflex.
Yes.
It's a 111, but it's more, if you go to the previous view, more in the circumflex than ostial LAD. But yes, we can define by the imaging if you want, but it's here, it looks like ostial LAD may, but this patient has a positive FFR. But remember, there is a distal left main disease. You'll have FFR positive on both sides. So this doesn't explain, does not confirm or rule out that there is a LAD disease or not, ostial LAD. So I don't know, angiographically, it's a borderline. Unless we want to shift something with the imaging, that will be different. But yes, very calcific. You see the tram track sign. And we felt always with the calcium, that start with the atherectomy. So tell us, Anu, what is your plan? What do you want to do?
There's moderate size. I would say actually small, diagonal. If you see in the cranial view, there's a diagonal diseases. Can you see that here? Which I
Yes.
think we'll leave it alone.
Further down.
Yeah.
So it is not a
Not at the
another-
ostium,
yeah,
but
yeah,
further down, yes.
Okay. So,
Now
but
I'm just thinking that do we do rota in the circ or rota into the LAD? You know what? Let me wire into the LAD and we just quickly image. Looks like ostial LAD is involved.
okay.
Yeah. And the
Take
plan
that.
should be that. No, hold on. What size foot?
Yeah. If at all we do the bar 1.5 for the circ, what do you want to do? Yeah, 1.5 will be okay. You're too
Not
good.
circ. We were planning LAD. No.
So LED should need a little bigger bar, but I think that's okay. I say whatever what learned in the era of IVL, smaller the bar, better you will be because you'll have a lower complication because you can always combine with the IVL if necessary. That is the key.
So, several questions have started coming. Dr. Ravi Kiran is asking, do you
Yeah.
think there is a
Get ready now.
ostial circumflex nodule?
Well, that's a very good point. So we will show that with the IVUS which Anu is planning and the team, and of course Kiski is all ready to make that comment because the paper just came out, the management of the calcific nodule and the algorithm which they have created, and we are going to show that algorithm next month. So now here she's going a direct wiring into the circumflex or LAD. Yep. You
No,
want to
you're
go to
saying
next order?
rota into the LAD and open one fiber.
Okay.
So, the next question is, what access did you have and was radial considered?
Yeah. So very good point. So we actually had the femoral in this particular case because we thought we'll require two
7
stents
French.
strategy. 7 French, yes, you can do 7 French in robust patient, but I think 7 French, bigger the size, we always know the higher is the radial occlusion. So in this particular case, so we, because of that particular region, despite the obesity, many of those cases are getting the radials, but we felt that we go with the femoral. Okay, so this is now wire is into the
And,
circumflex.
the magical fingers have gotten the wire
Closure.
there.
Yeah, the direct wiring of the circumflex at this time.
Okay, give me
and-
the IVUS.
Yep.
No torquer, nothing at all.
No.
Yes. Okay, so we are ready with the IVUS here. So while I was getting ready, let me just complete
I just want to go back to the radial axis. I know everybody think by doing radial axis they're going to become heroes, but the radiation for the operator is the highest when you do radial intervention.
Well,
But
the
at this time, yes.
operator, patient, and the staff, everybody is included.
Yeah. But when you are doing this kind of high risk procedures and high volume procedures,
So this patient has syntax score of 24, EF of 60%, had a discussion with the surgeon, but declined because of, there is some issue about the cervical cancer and comorbidities, so we decided for the PCI. So that's what we are going to do now.
This is quite amazing, actually. The similarity between the two cases.
Yes.
And the age is the same. Sex
Yep.
is the only difference I realized was the other one had a syntax score of 36.
Yeah.
And that would have been my first question to you. That, of course, that would have been factored into considering the best approach.
Let's wait one
okay,
second.
can you
Wait one
see
second.
the
No.
thing?
Okay, I
No,
check
just
the
one
image.
second. We just finished this one. So this is our plan is rotablation plus minus IVL and mini crush stenting, and just wanted to show all criteria. We always show left main plus 2 vessel disease this particular case. So it will, remember, left main always will remain
High
part
vessels
of
in the
the
left main.
appropriate is for the cabbage, but M there, but once you have the heart team discussion, there I would say still become A after heart team discussion. As you also know, to update in the, at least the European Society of Cardiology
So that is-
guideline just came out that in particular patients that syntax score less than 22. This was barely 24. So those cases could be class 1 now, even for PCI, because they're saying that if you do a complete revascularization and outcomes are good and lower complication, IVUS is okay. PCI is okay in these patients, and of course, high-risk patients get 2B. So that's where we are, and I'm going to show it now. Go on the fluoro, and they had a trouble or advancing the catheter into the circumflex. You did already? Okay. The advance, tell us now the nodule versus, you want to do the LED or no?
No, the thing is, I think one fiber is too big.
Looks it didn't cross
Too
to
big?
the osteocirc.
For the
We're not
circ.
able to, yeah. Okay, that's where it's not, look at the, okay, calcium is
Yeah, this is
like a
just,
2.5 quadrants, right?
Yeah, just
we are
research distal
we are
left main.
not seeing. We are
IVUS,
not, okay.
yeah.
Now we see it.
Yeah, it didn't cross the osteocirc, so
Now you
we
can
started from the
conclude it.
distal
Now
left main, like a
Enough
180 calcium,
of everybody. Yeah.
and a very short, like short left main.
But we don't see the nodule then.
No.
just
Why, who's made a nodule?
because we didn't cross that tightest part, so we just saw the distal left main, and the area is like a 5, so definitely left main is tight.
So basically, the catheter did not cross the ostial circ.
Yes.
Right?
Yes.
So just to, we had the catheter. So key is, we know inability to advance the, your imaging catheter qualifies to be a severe calcium. So therefore, whether it's a nodule or not, we cannot make a point. What about OCT? You think OCT would have gone?
No, I would not even think about it.
Okay. Okay, so now what do you want to do? You want to go to the LED? And now question comes that if it did not go, do you go to 1.5 bar or 1.25 bar? That's a question. I think it will be reasonable to go with a 1.5 bar, which we have ready. And if we see any much deacceleration, you can always go down to 1.25. Fair? And then we'll do the LED later to see whether LED osteal is disease or not.
Yeah.
Again,
LED,
image guidance.
I think we could just do IVL.
Yeah. Okay. Okay, let's go. We have 1.5 ready. So LED question comes is how much disease we will say after the septal. So LED they have a moderate. I think we should do the imaging of the LED also based on what quadrant calcium it is. And is there any calcific now? To answer the question to one of the participants, is there a calcific nodule at the ostial circumflex? You want to do IVUS after the initial rotablation?
I mean, another related question, any role of physiology here?
Yeah, patient already have a ctFFR done.
was positive.
Yeah, remember patient has already. And as you know, that once you're ctFFR positive, you cannot bill the patient for invasive FFR, in America at least, and Medicare patients, so they will not pay for it. So therefore, we made in our cath report invasive versus ctFFR, and if the FFR is positive by CT, we just put that number. Because you can do it for theoretical purpose if you want to, if there is a question, but you will not be paid because you have, the government has paid you for the ctFFR. Hold it. Okay, this one, pay attention, please. Good. Yeah. Okay. So we have brought the 1 point. Are you okay to show us a little bit more? Yeah. You want to magnify? Yeah, too far
Isn't
already.
that a little unfair if the patient is being referred to another institution that somebody else has been reimbursed?
No, but for ctFFR, though,
No.
but remember, FFR is just for the decision making. Yeah, procedure is separate. Procedure will be referred for which the patient has been sent. But there is a wire.
Very
1 second.
tricky. Very
No, I
tricky
think no. My question is there a loop in the wire? If some obesity we can't even see. What do you want?
Wait, I'm just bringing it there.
Sine?
Oh yeah, there's a loop in
There's
the
a
wire.
big loop in the wire, which
You
is
did
okay.
not allow
That's a
it.
good
Okay,
one.
pull it.
Because some people do ask us one time to time, how do you no, keep it there?
Okay.
I'm going to pull the wire. Yeah. So good. And then pull back the guide. So the loop has been removed now. Good. So basically what you do, you just pull. Sometimes if you have to do the brake release or so. Good.
It's amazing how you spotted that loop.
No, you see
We
that
could not-
how the rota was
Yeah,
supposed to
but
go
no,
into the
we-
circuit was turned in. Yeah, yeah.
Right, we could not appreciate on
Yeah, now you see it's making into the
totally
circuit.
different. Yeah.
Yes.
Okay, you're through.
Proximal lesion. There is another lesion at the
No, I
ostium.
don't think we should go down there.
Yeah,
No?
but your gut instinct about 1.5 here was a very good one. Very good one.
Yep.
You
Let's
know,
go beyond.
so often we've had cases
No, don't take
where
You want to
IVUS
take
would
it
not go and
unnecessary
you
aggressive.
lean back into the 1.25, but this was a very good call.
Good.
This is your polishing run.
Yep.
No. That's enough. Come on.
And our fellows are actually independently doing the rotablation in most of the cases, unless some very complicated. So all got, we do about 65 rota per month. So 5 months have been about 300 and there are 8 fellows. So all have done about 30-35 rotablation. Orbital is about 10%. And now the question is, after the Eclipse trial, we'll talk about what will be the fate of the orbital, whether it will increase, decrease, or disappear.
I can tell you if there is one institution which got this as a 2A guideline recommendation, it is Mount Sinai. I mean, you've led the way since I think at least 3 decades now. It isn't even 2. It's and I have watched this amazing progress. Looking good.
Yeah. So what is the next step now?
No,
You want
I
to
think
try the
we will-
IVUS again on this?
No.
Huh?
Let's wire it. Let's wire with the
Yeah,
run
so-
through for the LED.
So no.
And then,
Run through for the LED, okay. And
And
then maybe
then-
same run through goes to the circ, see the ostial, and
we can
then
go
decide.
with the
So we-
fielder, no?
Okay,
the
we get a
circumference.
filter wire also. Let's get it ready. Yeah,
Yeah.
everything is ready.
So, I mean, many other questions. This is the first time I'm reading this name. I will read it slowly to get it right. Alexander Pasechnik. Probably got it wrong. It's either from Ukraine or from Russia. Hello, do you consider any complications with rotablation related on size of the burr, more with 1.25 or other sizes?
Very good point. So I would say that if complication increases with a rotablation will be once you go beyond 2 millimeter. And if your vessel size is less than 3, you go beyond 1.5. Now, just to say, there is a trial we did called Stratus trial, STRATUS. And that's in my early days of 90s. And what we did is, what we did at that time is that we had two strategy. One, the burr to artery ratio of less than 0.7. So we are used to use 2 or 2.25, burr during the time. So 0.7. So basically in a 3 millimeter burr or 3.5, so 3 or 3.5 millimeter vessel, we'll use a 2 burr. Then the second was the aggressive. So conventional and aggressive strategy was 0.8 and above. So we are using 2.38, 2.5 millimeter burr requiring 8 and 9 French guide catheters. So we found basically that by using aggressive burr, you have a more deacceleration, more chest pain, more CK release, and then more restenosis. So therefore, yes, and then of course higher complications. So aggressive burr, and that is why we came up with that strategy that your burr to artery ratio has to be between 0.3 to 0.5. And in this day and age of IVL, I would say let it be 0.3. Nothing wrong in that. So clearly bigger burr, yeah. Whether there will be a difference between 1.25 and 1.5, I would say our personal experience has been that if you could not get your over-the-wire system and you use a 1.5 burr, you'll have more slow flow.
Kiski,
And that's why we always go with the 1.25.
in the circ, okay?
Yep.
Okay,
So
we're doing
Dr. Mahmood El Rais, who's very frequently with us, has asked if the lesion is very tight, 90 to 99%, do you really need FFR?
No. So the idea, the guidelines are that you need FFR for lesion 40 to 80%.
Can we see?
So I check
40 to
image.
70.
Yeah,
No, I
40
don't
to
see
70%.
No, no, still aorta.
Okay, good. That other lesion, I think, distal, where we didn't go with
Didn't
the
cross.
first.
No, but it did not cross the ostium.
It does not cross ostium because the tip is not making a turn with the second lesion.
Okay, so just to say that despite the lesion, now you want to go to the LAD?
Yeah.
Right.
Change the IVUS.
That LAD ostium or not? Go.
Anu, several people have commented on the very elegant use of the 1.5 burr.
I really think we should have gone 1 to 5 and gone into the distal lesion. You see that
Right,
circumflex? Yes. I think 1.5 would have been
lesion,
aggressive to make that turn.
Yeah, I saw you
Yeah.
kind of touch it and then back off.
Yeah.
Yeah, but we still touched it. I think that's enough.
No, but right now IVUS is not going.
No, IVUS is not going for some other region.
No,
also.
no. It's not making that turn there. Okay, let's see.
Welcoming Alexander again. He's clarified he's
So
at
what is happening
Kiev,
with this IVUS catheter?
in
It
the
looks like
Ukraine.
coming off.
No.
Yeah. See, IVUS
Probably
catheter
got
is
destroyed.
yeah.
No, come
Yeah.
back.
I'm holding. Yeah.
Okay, good.
See,
Not
what
bad.
is happening with this?
Yeah.
I think
It's
cath-
just
Catheter blocking, catheter blocking.
Huh?
Catheter is blocking. It's too apart from the tip and the camera.
the new catheter?
Yeah, new catheter.
Yeah. So that's why maybe we'll use
no. What happened? Probably first time our attempt with the circumflex.
became separate. Okay.
Yeah. Now let me take out the. Anyway, let's have a double wire. And see how it behaves. Yes. Use the same thing.
Yeah, these are flimsy catheter. Now tell us about one catheter which has both IVUS, OCT, NEARS, and what is the story with that? No, just say.
Talking about Spectra Wave, is it?
Yeah.
Yeah,
Yes.
yeah.
That's the company I thought which was recently acquired by
Yeah, keep flush.
Johnson & Johnson.
Johnson. Yeah. Yes. So question is the people, there is a need for demand for it? I mean, I know, but that it was a big announcement that recently acquired by the J&J. Good. One second, don't go ahead. Good. Now, okay, let's see now. So there was a catheter issue, whether that's why maybe it did not go into circ, we'll see now.
No.
Yeah, we'll see.
No. The catheter, probably the tip
No,
got
we don't
destroyed when
know.
we tried the
I know
circumflex.
earlier, I'm not
beginning,
saying
yes.
now, that after rotablation, in my opinion, your catheter should go. Okay, you're going to the circ.
Yeah, it comes. Yep.
Okay, that's good enough.
Okay,
Yep.
can you see
Good.
now?
Yeah.
Can you flash me? Yeah, okay. Start
Okay.
pullback. It's coming. Eccentric calcium. Now osteocirc here. Not that like a protruding. It's not that nodule. Anyway, I stop it. And I show you the osteocirc. Yeah, so this is the left main bifurcation. So then this is the osteocirc. Actually not that calcified, just a 90-degree, but eccentric like a plug, but it's not that, it's not nodule.
But just the eccentric, yeah.
Clearly that would have already been modified with the rotational ablation.
After the loader.
Yep. Did you see any cuts, cracks in the calcium or no?
Actually, I mean, not that severe calcium in the circ.
Okay. But there's no calcific nodule, it's just a calcific ostium. Is there a 360, I know 270 or any area of the 360-degree calcium?
In the circ, no.
In the circ?
No. You don't
just
see that.
180-degree in the circ. Left main has 180 to 270, but circ is 180.
I see. Here look like 270.
Yeah,
Okay.
that's the distal left main.
Okay. Talk to the patient. Yeah. Okay, now we are going into the LED. See, I think that was a little defective catheter, but anyway, we are ready now for the, bring the, on the, IVUS on the main screen now live.
No. Okay, fine. Yeah.
Went through very easily in the...
Yeah.
So
LED, yeah.
it's a LED. Yeah. Huge size gap, eccentric calcium, left main. I will stop it.
What is your speed?
4.
Good.
Looks even like there's more calcification in the LED than in
Yes. LED
No, that
also
is
has
just a
very
little ostium,
eccentric.
or it's left main.
So this is the left bifurcation. After that, this is the osteo LED, eccentric calcium, because other part is totally healthy. It's a risk of the perforation. Yeah, 180 calcium.
Okay, osteo LED is 3.3.
Yeah, definitely tight. After the blanch, like a
that's what I said.
270
But
calcium.
that's it. After that, it looks okay.
Yeah. So let's put a same rota wire into the LED and let's do it. And we can open the ostial circle a little bit with the balloon and put a rota wire. So people always ask when you work with the bifurcation, how do you work it out?
No, SS, you don't need rota into the LED. If you need it, we probably need it in the beginning with 175 bar from left main to LED.
Okay.
Right now, go back to the distal left main.
Sure.
Yeah, right there. Yes.
See, the 270 plus degree calcium.
Yeah, but
So the rota will cut that calcium also, which is okay.
go back to the left main.
Yeah,
Distal
this
left
is
main.
pull back from the circ. Yeah, this is more like a clear.
Yeah, stop there.
270 calcium at the distal left main.
And on the top 12 o'clock, is that a nodule?
No.
Yeah, I mean, yeah, well, you're right. A little bit protruding. Of course, we need an OCT for better like identification. But this is not the circ. This is a distal left main. Slight nodule.
Okay. I think to me, since we have already stuff, I think we should open the ostial circ with the little balloon and then put a rota wire into the LED, do a 1.5 bar. We have it. We'll make one more cut.
1.5 bar will just fly. If you need something, it's already 3 millimeter diameter of the distal left main.
Right.
If you need something, even 2 bar will just fly through it.
Yeah, no, we know that.
Yeah,
so we can do a 2 if you want. Or what do you want to do? Tell us then.
No, I think we can just either you want to do IVL or a cutting balloon and just stent it. I don't think we need rota right now.
Okay. So we can use IVL if you want.
Kiski, what do you think?
Yeah.
The way the calcium, I know we cannot give the
most severe calcium is a
thickness.
distal left main at 270.
Yeah. So since it's just distal left main and ostial LED is not a lot of calcium. Go back to ostial LED so they understand why we are thinking the. Go back to ostial LED.
This is
so
actually
distal left main, you can see the calcium.
Yep.
Okay. That is 3 quadrant.
Yep.
Good. And then when you come to ostial LED,
Yep.
it's not calcified.
Not that. Like 90 degree.
Yes. So that's why I'm saying you can even do cutting balloon.
Okay.
Yeah. But you want to receive, because of the distal left main, you have a 3 quadrant and you think you want IVL. But then if you need IVL, we need 3.5.
3.5, yeah.
Yeah. So we do
3.5.
3.5 IVL into the LED.
And what about the ostial circ? We can use
No,
ostial circ also.
ostial circ will be just balloon.
Okay.
Samir, is it clear what the thought process is, which device to use?
Absolutely. I'm glad
this is
that you...
The imaging guided,
it.
yeah, that's how.
And the very unique part here was that you asked Kiski's opinion. Look, based on imaging, what do you recommend?
Yeah. So remember, this is, I think, and then Kiski, we are both, our
You know, we've been
waves are same.
watching Kiski do her all the imaging. The other day I was talking to him and I realized he has done 6 years of interventions in Japan.
Yeah.
So you've got a highly accomplished. So I'm not surprised you asked him, and his reply was one of a very elegant interventional cardiologist.
Yeah, so basically just to say that we are just adopted going with the IVL because of more for left main rather than ostial LAD.
Ostial LAD you saw barely 90-degree calcium. So left main, that's why I said also no point doing rota. Okay, it's a small bar in the left main.
Unless you use a bigger bar. So that's fine. The IVL is good. And as you know, that cracks even in the trial of the R3, comparing all the various techniques. So basically, it is the IVL creates a maximum number of crack in the calcium compared to any other, whether it's the atherectomy or laser. So basically, the IVL really creates a more cracks in the calcium. Okay.
And that's one thing. And the second thing is what Dr. Sharma was mentioning, that balloon the circ and then remove the wire and then rota of the LAD. I think at this stage, we should not be doing that. After you balloon, you remove the wire. So that's another reason that IVL probably of the distal left main is a safer technique now.
It's a 3.5.
Yes.
We are going in.
And then get the IVUS ready, Maria. Yeah.
Yep. Ready.
Okay, so
Good.
we are there.
Yep. Go up.
Right there.
4.
Okay, go up. Okay, so down.
Huh?
Come on,
No,
in the LED more.
Okay, but we started the.
No. Okay, go down. Yes.
Okay.
So most of it is deep calcium. Kiski, look at the angiogram.
Yeah.
Okay,
Looks
a little more, yeah.
A possible case for IVL, huh?
Good. Yep, this is it. Ideal. So this is the 3.5 IVL. We are going with the.
Can you show some EKG? This is one thing about IVL in the left main. I think we cracked it, right?
Yep.
Earlier you had that dent.
Yeah, 6 and down. Yeah.
You see that EKG changes?
Yep.
Okay, I think you want to do one more?
One more, a little further down, 1 millimeter further, no? Like a center. Good. Go up here again. And then little proximally we can do 6. Hold on, yeah. Yeah, good.
No, I don't think you need proximal.
I think.
Okay, keep going. It was the calcium was just in the distal left main.
Maybe 28 or something.
Yeah, I think it's good. We can take it out now. Okay, what do we have for the circ?
We have 3 or 20 balloon, high pressure.
Okay, down. Okay, let's get the IVUS. And the other thing also is that once we do IVL, I typically don't post dilate after this balloon. We can just stent it.
Correct.
Now we can balloon the circ compared to after rota.
Lot of ST changes.
Yeah. This is one thing when you're doing the left main. You see the ST changes.
Well, not only had you anticipated it, you were asking for the EKG to be shown, so you're exactly right.
Yeah. In our Calcific app for the left main bifurcation, we have not included IVL for this reason, because as soon as you go up on the left main, we have seen a lot of EKG changes.
Samin, there's again Dr. Mahmood El Rais is asking, could you do rota of the LAD with a micro catheter protecting the left circumflex
Yeah,
flare?
so very good point. Yeah.
Not
so,
micro catheter.
Anything, guideliner, Godzilla, micro catheter. But remember, then you'll require about 7 or 8 French guide.
8 French guide.
8 French guide. So you could, if that's the plan, then you go. But I can tell you that we have done so many thousands of rotablation. We have never used this technique. I know this has been reported, and people, those are very much concerned. But then you have to go with the 8 French to begin with. You need 8 French minimum. microcatheter, guideliner, whichever way you want to do, and then you put a wire side by side.
Okay, now Kiskin left main again.
Sure.
Sorry, LED. So I'm
LED,
going to
okay,
pull back.
start
Just
pull
do
back.
the left main. Yeah.
Yep, coming.
Can we go slower?
Sorry,
Yeah.
I started, but I see some fractures already.
Okay.
Yeah, I will stop it.
Okay.
So,
Okay, now just the distal left main.
Yep.
Focus there.
yeah,
Give
this
us
kind
the
of
balloon
clock
for the
here, and the
circumference.
area is like now
Yeah,
it's
have it
7. It was like a 4 point something, but it's not 7.
And
You
do
know,
you
frankly, I would have expected more fractures there.
Yeah, it's an IVUS resolution, so maybe OCT we can see more.
Okay.
But
he's saying if it
even
was
by the
OCT, we would have seen better.
yeah, but even by the IVUS we see some calcium fractures. So at
Can
the,
you? Can you? Yes. Yeah, right there.
yeah,
But that's at the edge, not
yep,
at the plate.
Yes.
The plate hasn't been cracked.
By IVUS resolution, so we cannot see.
You mean you're saying IVUS, we won't see it?
Actually, like how intense
That's
the
another thing, you
fractures.
see. This in the sides.
Hmm.
Plate itself has not cracked.
So Kiski, if you can show to our audience the crack of the calcium of the distal left main, if you saw
No,
any.
he showed, but he's saying
how many?
the plate has not been
At
cracked.
least
It's
one.
the edge.
At least
but
one.
here,
So
yeah,
yeah,
crack,
and,
that's
No,
the
no,
plate.
No.
Why?
No, it's edge.
No, what about the sand at
No, that's
2
the
o'clock? That's the wire? Okay.
Yeah, wire operation.
it should
Now
be
it's a 3020 non-compliant balloon going into the circumflex. Good.
Okay.
Yeah, this was the area, Anu, you would have wanted to address the 125.
Yes, this is what I wanted. But
Okay,
you see
16.
now, you see how the vessel is, and if I had gone 1.5,
Could have
Now there is a little
perforated.
bit of band. So you want to go a few millimeters because we should cover that with the stent. Otherwise we'll make it a new lesion. Because there is a calcium and slight band. We'll go at that band to cover the balloon. Good. Yeah.
okay.
Good. We are good. So it's a 14 atmosphere, open nicely. And then we'll do the distal left main and so.
But what should be the length?
Yeah.
28.
Yeah, here 28. You're at 28, 3028.
So what's the distal left main
I'm going to bring it
area? Not means. Do we take a 4.0 or a 3.5 for the LED?
LED, like after the diag is 3.0 vessel, huge size gap. Proximal is more than 3.5, but after the diag 3.0 vessel.
Okay, so then we take a 3.5.
Yeah.
And
Or
length.
3.25. Okay.
Oh, okay.
Let's take a good picture now. We are done here. You want one more? Okay.
Okay, good.
Distal left main to the circ now.
Yeah. So nicely opened up.
Yes, I mean, more questions. Interesting one. Did you consider IVL for the circ too?
Yeah. No, we talked about it. Yes. So the felt that there was no the calcific nodule.
No.
Because we actually have the more cycles. Let's take a picture. So just wanted to go balloon region is yes, you can always do, but based on the imaging, felt
And
that
also
it's not
the
needed.
intense- yeah, right. The calcification
let's take a
was less
picture.
in the circumflex
Yes,
than in the
yeah.
LED.
Yeah. Based on the imaging we are talking about.
Yeah.
Right.
But
If-
otherwise, yes.
If we
Look,
can,
Anu, the joy for me is how carefully people are watching.
Watching. No, but I think at the same time point I can say if somebody wants to use that IVL to the ostial circ, nothing wrong in that.
Right.
Yeah. Let's talk about the stent strategy now. Yeah.
no, but
wait 1 second.
if we have done that, you wanted to do 1.0 or 2.0 bar in the distal left main to LED, just the ostium of the distal left main to ostial LED, and then you do IVL of the circ. That also would have been a okay option.
One of the questions it's coming to my mind watching exactly the frame you had there is that would you want the left main stent to be almost close to the ostium of the left main?
Mid left.
Mid left.
Mid.
Okay.
You can see even on the imaging. It's
3.538 for the LED and 3.028 for the circ, right?
No, he's saying if you put 38,
Yeah.
after the diag, it is 3.0 vessel. It's
Yes.
too big.
Okay, then
And
3
if you
or
go back
3.25.
here, so if you go back here, see there, 38 is too long, and
Okay.
diag is so close, it's septal. So based on this, okay, you should be, if you're taking a 3-5, you cannot be more than 20 length. At the max 24 maybe.
Okay.
Otherwise, you want to put a 3-5.
Or 3.25.
Okay.
I think we have to go in this view. See, there is a moderate disease before the diagonal. We should come up to there, 38. If you want, or maybe even longer.
Okay, yeah. You want to cover, then you have to cover all the way subtle till here.
Yeah.
Now, Kiski, if you go to the cranial, come here, look at the cranial picture.
yeah, I
We have the septal, and after the septal, there is a
Moderate
at
disease.
least another 15,
Yes.
20 millimeter disease.
Yeah.
What do you think?
Yeah,
Right?
it's true. Diffuse lesion. We couldn't see the healthy landing zone by
Could
the
not,
IVUS.
right? So you want to put a 33?
Yeah. My only question is, what about the second diagonal there? There's moderate disease there.
No,
Why
no,
don't you
no.
cover all throughout?
No, no,
No?
no,
Okay. That's fine.
no. You're talking there, all the
Yeah.
way here?
Yeah. From here to here, 48.
No, that's
3 48. That's one way.
I think we go 30,
No?
38.
38
Get
will
us a-
not come to the wrist left main.
No, we'll
If you're
go
talking
from
about,
here
yeah,
to
that's, yeah,
here.
then fine.
Yes,
Then
that's it.
33 is okay even. 33 or 38?
38.
Okay. 38, 3.25? Or what? So 3.0. Yeah, we are using a synergy. Tell us what you want. 3 or 3.5? You said the
Hold on.
LED after diagonal was 3.0.
Yeah, I know. What's the left main?
Left main is like 4-5. Left main is 4-5. Huge
3
size
is
gap.
not going to go to 4-5.
Huh?
3 will not go to 4-5.
Yeah, it's
Yeah.
true.
Then let's say 3.5.
No, get 3 to 5 don't exist.
No, not the synergy. Doing synergy.
Not in, yeah, science.
No,
You
but
don't
now
use
you
it.
have said synergy, they're opening, yeah. Okay, we can use a 3.5. I'm telling you, we leave at moderate pressure, 3.5.
So Samin and Anouk, some corrections and updates here. The
Tell us what you
person
want.
I
we
want
had
3 to 5, 33.
Yeah, huh. Sorry, yes.
identified as a Ukrainian cardiologist. She is
Oh, wait.
Alexandra. And I've had a delightful chat with her in which she's even informed me that there are 12 to 15 functional cath labs in Kiev. Excellent. So nice having you join us,
Okay, get us a
Alexandra. And of
3,
course,
5,
I've been telling her
38
to
synergy.
seek out the CME too.
And then 3028. First, give us a 3028.
Very good. Fantastic. Welcome. Welcome, Alexandra. So this is now we are going into the circumflex first.
Tell her we have a 3 key Ukrainian people working with us.
Of course, I
Andrew
of
Andrew
course
is
I
from
let her know.
Andrew is from
Kiev.
Ukraine, Yulia is from
Yeah.
Ukraine, and then we have our special nurse practitioner Nelia. She's from Ukraine, and they are from 2 of them are from Kiev. Yulia is from Kiev.
Right. I did let Alexandra know that.
Yes.
Yeah, we very well know. We work.
Very closely with them, and they have made such a big difference.
Yeah,
Big. Yes.
Exceptional. Both
contribution
of them,
to us. Yeah.
absolutely tremendous. You know, it is so. I can give you my perspective, looking from a distance, how much contribution they have made, Kiski had made, and they're just amazing. Each time you walk outside the room, they are hard at work, always. It's a little bit of a surprise, the struggle you're having.
No, we'll go.
That's the 3 to 5, no?
No,
No,
3.0
3.0.
synergy, 3.28 synergy in the circumflex. So
Yes,
question is, we may need one more wire.
Angulation.
Get a run through wire, yeah.
Buddy wire there.
Take a deep breath.
I did not want to go there.
Yeah, but that angle is the troublesome.
Yeah. Sharp angle.
Yeah. You can leave it, put another wire, run through. Now, it's only the fielder which didn't provide that much support, so we are going to put a run through wire. You can always put a guide liner on the one side, but I don't think or Godzilla, but let's leave it and let's go to the run through wire side by side. And this is that angle we expected will be a trouble. We dilated nicely with the balloon. But this is the same, it's the nature of the calcific lesions.
Yeah, angulation and calcification.
Yeah, that's right.
I think just this another stiffer wire will do the trick.
That's okay. Good. And we go on the run through now.
Now we'll have
that
to same.
That will do it.
Okay, good.
So we have buddy wire in the circumflex. The fielder was there already, and now we put a run through and going through it on the run through now. Yeah.
Just as asides the live case today, did you do live cases for the TCT?
Yes. So we did 2 live cases, rotablation, one with the rota with the Anu did and I did with the orbital.
Fantastic.
So came out both perfect. Very good. A lot of teaching points.
Did we take a picture? I don't know. We want to do a.
You want to just dilate with the balloon a little more?
It's going, but
Or you want to anchor the LED with the LED balloon? We can do with the LED balloon, right?
Yeah, it's too much.
Now various techniques we can do now. We just do a little balloon in the LED, anchor it, and then this will go.
It's almost there, but yeah.
I know, you need a little more. Leave it there. Let's get a LED balloon. Give us a 3O balloon before we had. Yeah.
No, 20 no. Then you'll.
No, in LED will go. Yeah.
No, that's not the thing.
Go.
I needed a shorter balloon. Wait.
This is the one. Yeah. So just to show another technique, the take out, put a Godzilla or guide liner, or second is now we are doing a little anchoring on the LED because we had enough length of the LED stent, so that's okay. Now otherwise you have to go with a short balloon.
No,
you
cannot do Godzilla because you can't take it out. Then you can't do 2 stents.
Yep.
Yeah.
No, but one stent and then deliver and then come out anyway. Yeah.
No,
will
then
be okay.
there can't be mini crush.
Yeah.
Okay, now anchor there. Why I didn't want 20 is we're not sure whether we will.
No, but we'll go 33. You already have the balloon there. Good. Now let's go with the stent. Good. Leave it there. Now we are going to do an anchor and now go. Have to bring guide a little bit more.
No, I'm telling you.
Take a deep breath.
Okay. Slightly.
Made it. Good. No, made it. Good.
Okay, good.
Take the other wire out. Breathe normally.
I mean, excellent demonstration. How high were you on the LED balloon?
6. Just 6 atmosphere.
Exactly as the term says, just to anchor it.
Yeah, anchor it. Yeah. Good.
Now what are you doing? We need the other stent.
Yeah, exactly. We take it out.
Okay. Yes. Don't pull this.
Yeah.
Get us the LED.
We have it. Here it. And that we deploy at moderate pressure because after the diagonal vessel is just 3.
So in the meantime, I did not glance the note. High pressure balloon inflation for the circumflex was also being mentioned.
Yeah. No, we did earlier, 20. Remember we had 3O, I went up to 20 atmosphere.
So
but now we didn't go 24.
Right. I think this is the note after as the struggle was continuing getting across the circumflex.
Right. No, that is true.
Before the anchoring. Yeah.
Right. So question was, if we needed to go back, we probably needed another maybe 3.25 balloon and go again further high pressure. And so, because 20 was okay, maybe go 24.
This reason we were struggling is the way the angle is and then the calcium.
Yeah.
That we have otherwise done good preparation.
And tortuosity.
Yeah.
All combination.
Combination of tortuosity and calcium.
Yeah.
Okay, let's see if this goes.
All right. We are going in now. Good. Okay.
Now, where is the circumflex? Okay.
Yep.
Okay. We can show the animation by the side. Okay, ready?
3.5 in the LED.
Yes.
Yep. Good. Looking good.
Is the animation coming up?
Yeah. Ready?
Mini crash? Okay.
Okay, we are doing the circumflex first.
Yes.
Beautiful animation.
16 atmosphere.
Okay. Down. Go up again. And then what we will do, we remove the balloon, we remove the wire, clean this.
It's such a lovely animation there.
Now automatically your LED balloon will move, or stent will go a little further. So make sure you reposition it.
Okay,
Now-
now.
Yeah, you
now
want to see
some
little die?
Yeah,
Okay.
some dye. What do you
Good.
think? Yeah, good, right? Because we need to be able to do
Yeah.
pot also. Let me take out the other wire.
Yep.
Only
Then we-
issue is we do, both are same color now. Both are okay. Some dye. Let me see. No, this is LED.
Yeah.
No,
Leave it in the guide. Good.
wait.
Okay. We're going up now.
The after pot. This is the wiring. Can you see the wiring?
Yes, yes, we do.
Yeah. Just you see straight forward wiring. Okay. And then we have a circ balloon, and then we have the LED balloon. Give me the LED balloon. So 3O high pressure balloon in the circ and a 3.5 in the LED. So we are going to do the kiss, and then we are going to image. So we are another proponent of pot, kiss and done, not pot, kiss and repot.
Samin, delighted to tell you that another interventional cardiologist from St. Michael's Hospital, Sirhil Chaichuk, has also joined us. So,
Beautiful.
and they actually wrote to me that they constantly watch the streaming, and of course wish us well, and said
Circumflex.
that they have benefited
What
a
is
great
this?
deal. So welcome to
Circ-
all of them, as well as
18.
to Dr. Arun Nagarjun.
Yes.
Nagarjun.
Nagarjun
Yeah, we know
from
him.
India.
18,
Yeah,
Very
20.
well. Yeah.
Probably
Right.
should be from Hyderabad, I think.
Yeah.
Okay, good. Down. You go.
Nagarjun, that's the right pronunciation. Sorry
Okay,
about
good.
that.
18. Okay. Okay, good. Okay, down.
No, it's Nagarajan. I'm sorry.
10.
This is, once again, I stand corrected. Arun Nagarajan. That's the correct pronunciation finally.
Okay, down. Okay, hold on. Let me pull this back. Let's do one more kiss. Okay, go both.
Now the keys, you get a proximal both dots at the
Yeah,
ostium of your left main stent.
good.
Because that has to be the key.
Okay, can we show the down imaging multiple times again, or you think we got the?
No, we got everything.
Okay, good.
In the end, if you want to show after I present, will be fine. You can do in the end.
Okay, I'm
But
going
let's-
to do the IVUS now.
No, but have
You
you,
can start
take
your
care of the proximal edge at all?
Done, done. We did a pot.
Okay. All right. Beautiful. Okay. Let's go to the presentation.
Samin, one
Yeah.
more quick question, if you can
Yeah.
answer. I think
Sure.
very relevant. Dr. Ravi Kiran, best views for the left main carina.
Yeah.
It's a caudal. What
Caudal.
we are showing, AP caudal is the best like we have, because LAO caudal based on the body habitus could be, hard, something RAO, but most is caudal like we just
Caudal.
showed here. Caudal
For
is
the
the best.
carina has to be caudal,
Yeah.
whether LAO caudal or RAO caudal. LAO caudal problem is there is so much diaphragm, you may not be able to see until you really do a cine and high intensity fluoro and cine.
So
Okay.
AP is the best, and
Yeah.
then cranial is if you're doing ostial left main.
Yeah. Okay. So they'll just show us in the end the IVUS, and now if we are okay now, we go our presentation, please. We are good here. So what I'm going to show is some key trials from the TCT, and the focus review is on this issue which we had talked about, the lithotripsy, IVL. from the Michigan BMC2 registry. So clearly the trials, there are many trials, but we'll just show with the most important, I would say, the landmark trial of the TCT. There are a lot of imaging trials, which are like practice changing trials for the imaging, but sorry, for the structural, like early tower and unload tower and all. But for the coronary, I found the real practice changing trial is one that was the Eclipse, and that basically was orbital atherectomy versus conventional balloon angioplasty in calcific lesion. This was a trial, took many years to complete, but 2,000 patients in a basically orbital versus high pressure balloon dilatation. Cutting balloon is allowed, but no IVL and no Rota, with the two endpoints. One was the post PCI stent MSA by OCT, and second is 1 year target vessel failure. People were very much waiting to have the results of this trial, which finally came and was presented by Ajay Kirtani, orbital atherectomy conventional. Basically, there were two hypothesis going into the trial. One, that you'll have at least 1 millimeter bigger lumen with the orbital versus balloon angioplasty. So that was one, which is at the site of the maximum calcification. Second was from the clinical point of view, that you'll have at least 5% lower revascularization or TVF in the OA group compared to balloon angioplasty. So let's see whether we met that. So clearly there are about 550 cohort in the OCT, overall 2,000 patients were followed. You say severe calcium was present in majority of the cases. Various other points are shown here, but more importantly, that as you can see here, imaging was done in about 2/3. And some cases you have basically crossover, but very small percentage crossover. You see the OA was done in balloon angioplasty in about 4% of cases. Contrast volume and the total procedure time was much higher in the OA group, which you expect. And these are the procedural device usage at the level in terms of little more scoring balloon in the balloon angioplasty group you expect. And in the bottom you can see, although Rota and laser was excluded, but you have about 0.3, couple of cases, same way for cases for IVL. So, you know, you had to do few things because of the need of the case, but overall the trial did what it is supposed to do using orbital atherectomy. Now, in the orbital group, about 2% crossover. They could not get your bird down regions are there, or we call classic crown down. And balloon angioplasty, this one was about 5%, and various regions are shown there. And those are the cases then went to had an orbital atherectomy in the control group, and rare cases of IVL and rotational atherectomy. Now, with that note, overall procedural success was excellent for both of them. Strategy success and final TIMI flow over 98+% of cases. Now, let's go to the important thing which we're waiting. One, what about the complication? Orbital atherectomy, as you can see, that despite teaching that orbital have a lower slow flow compared to Rota, you know, all the Rota trials compared to balloon, there was never higher slow flow. But here we have a 1% higher slow flow in the orbital group compared to balloon angioplasty. Second, perforation was almost double. Didn't make a p-value, but 0.1, 1.8 versus 1%. So those are the two important complications which we had to keep in mind when we are interpreting the rest of the data. Then the primary imaging endpoint in the OCT cohort was your mean stent stent expansion at the site of maximum calcium, barely made it with a 0.256 difference. Remember, the difference supposed to be 1. Same thing at the MSA, 6 versus 5.87, about 0.6%, so did not make it. You needed 1% better, so p-value was not significant. So one endpoint was not met. Now the second endpoint, difference was 5%, but here you see difference was barely 1.5% in the other direction. That orbital atherectomy had a 1.5% higher event rate compared to target vessel failure compared to balloon angioplasty. So individual endpoint, and then OCT group definitely had a better outcome compared to non-OCT group. So imaging did help. Individual endpoints are shown here with a stent thrombosis almost 3 times, 0.08 with the orbital plus DES compared to balloon angioplasty but DES 0.4. So overall, you can nutshell say the trial failed to meet any endpoint. Rather, it was harmful, and there kind of even mortality. Look at the mortality. If I go back to the previous slide, cardiac death 4 versus 2.7. So overall kind of p-value of 0.12. So overall you can say, which is what the conclusion very nicely framed by Ajay Kirtani, that routine use of orbital atherectomy did not improve MSA or reduce TVF at 1 year compared with conventional balloon angioplasty for preparation of severe calcified lesion. So therefore maybe you should use it in selected cases, need to be seen. Second trial is the assured DES. Assured DES basically what question always comes up. Patient has 1 year passed after post DES. Now patient need non-cardiac surgery. What you do? You stop both of them, you stop one of them, DEPT, or you continue, or you give nothing. So this was that after 1 year of the DEPT, in a post DES, aspirin monotherapy versus no aspirin in the low to intermediate risk non-cardiac surgery trial done in India and Korea. So this is a randomly assigned patient, about 450, the 900 patient who had DES more than 1 year, and then elective non-cardiac surgery, and basically endpoint were very short acute endpoint. So basically you look at the left side, either aspirin monotherapy, P2Y12 monotherapy, or dual antiplatelet therapy. All those patients, when randomized, they stopped, then started aspirin alone versus no antiplatelet therapy. After 5 days, you can see everything done was 5 days before and followed for 30 days. And the endpoints, this was truly the intermediate to low risk surgical, cardiac risk factor based on the ESC guidelines, which they followed quite well. And they found the event rate was very low. Death, MI, stroke, and stent thrombosis at 30 days occurred in less than 1% of cases. Aspirin monotherapy 0.6, no antiplatelet therapy 0.9. And if you take other individual endpoint, the minimal myocardial injury and others, bleeding and all were stroke, all were non-significant. So overall, basically was that you give aspirin or no aspirin does not matter after 12 months, and you may make it a point that don't give aspirin. Now, bleeding, as you can see, if you give aspirin, there was some definitions of bleeding did occur higher in the aspirin group versus no antiplatelet therapy. So therefore, the point of after 1 year, this is again want to say, you have to practice the way the entry criteria was. This trial was done after 1 year of the DEPT in the DS patient. So therefore, no aspirin is reasonable that once patient going for non-cardiac surgery, as long as there is a low to intermediate. The high risk surgery, spine surgery, opening the peritoneum and so is not part of it. So therefore, low to intermediate surgery, you can remove the aspirin, as you can show here in this central diagram. Then, so therefore, they concluded that among patients undergoing low to intermediate risk non-cardiac surgery more than 1 year after stent implantation, primarily with a DES, in the setting of lower than expected event rate, we failed to identify a significant difference between perioperative aspirin monotherapy and no antiplatelet therapy with respect to ischemic outcomes or major bleeding, because event rate was so low. So anyway, the question is you can safely stop the aspirin. The third trial is the RIP6. That is the long-term results of bioresorbable vascular scaffold in patients with ISR. Remember, we always thought when we had the bioabsorbable, our absorbed stent available, that ISR is the beautiful or the best milieu for treatment of these cases using the dissolvable and biodegradable stent, and that was the BVS. So what they did is they compile, and then there are the RIPS 5 and 4 using the DCB and EES. So they took all the three groups from the RIP 6, RIP 4, RIP 5, the BVS, DCB, and EES, around 250 patients in each arm, and basically showed that MACE at 3 years was lowest in the DES group and highest kind of was in the BVS group. So BVS did not do any much, rather negative, as you can see in every point, and DCB was somewhere in between. Now, also they found between 1 to 3 years, and these are the individual events, as you can see, after 1 year, the curves start separating, that if you say the event after 1 year, that you see that the DCB was definitely better than BVS. So the green MACE, as you see in the center, 6.5 between 1 to 3 years in the BVS group, and in the DCB group was 5, and of course 5.3 was in cases with the ES, and of course with the TLR it was 2.5 and 2.0, significantly lower. So clearly key is that the DES of the everluminous eluting stent was superior to other strategy. That's one. Second message, that BVS has no advantage at all. Third message, the DCB did better between 1 to 3 years and in these cases and so. So that basically was that patient with ISR, late clinical event of DES are superior to those obtained with DCB and BVS. Beyond the first year, DCBs are safer and more effective than BVS, as I just said. Then the last one, just to issue, people have been, there's so many DCB trials are ongoing, will be part of the another trial we already have at present. The MAGIC and the sirolimus, the trial ongoing at present, and the many, as I said, in market at least 4 or 5 other drug-coated balloon trials are coming. So people do ask, what about the paclitaxel versus sirolimus? Paclitaxel is the one which was studied originally, and the agent DCB balloon of the Boston Scientific have paclitaxel, and then sirolimus, many other agents are coming with the sirolimus, now everolimus also, biolimus too. So question was, which one is better? And best data was from this multi-center registry from Europe and Asia of the paclitaxel drug-coated balloon and sirolimus drug-coated balloon. Large number of patients, as you can see here, about 1,000, the sirolimus is much higher, 2,000 patients, about 500 patients, the DCB group, and basically showed the de novo or ISR use, wherever we want to use. There was no difference in the paclitaxel versus sirolimus, exactly identical, as you can see here. In the overall, so seems to be that whether you use a paclitaxel or sirolimus have a similar outcome, and as shown into all these data and individual groups. So with that note, I just go to quickly to the focus review of the month, that is our contemporary management of coronary calcific lesions, that what lithotripsy has done. So this is the data from the Blue Cross Blue Shield, BMC of Michigan, Cardiovascular Consortium. So every patient is followed, and what has been the trend? And trend is very simple, as you can see here, since its introduction in the second quarter of 21. The IVL use has been going up and up, about reaching around 5-6%, little bit of sometime down and up, but overall atherectomy volume has gone down, which used to be about 5%, has gone down to around 4%. IVL use has gone to about 5%, and then some percentage, about 1%, using both. And you can see the yellow, both IVL and the rota atherectomy numbers are going up. Why? Because more complex cases you are using both of them. But if you take all 3 of them together, now about 10 to 12% of PCIs being done in this system using the atherectomy plus IVL, and that is what I have been teaching all the time, that you have a severe calcium in about 10 to 12% of cases, and I would say with the day and age, all those cases are being treated with some kind of a plaque modification. These are the individual endpoints and the characteristics, but more important here is the complications. So intravascular lithotripsy and atherectomy, you can see here, as we expect, less perforation with IVL, less slow flow with IVL compared to atherectomy. Of course, both will have a higher complication because those are the more complex lesions. So put it together here, intravascular IVL with atherectomy, large number of cases, great procedural success of about 90%, MACE rate about 4 to 5%, and no difference except lower slow flow and lower perforation in the IVL group compared to atherectomy group. Now, if you put the both, there of course some complication goes up when you have both IVL, or we call it a rotatripsy. It will have a higher MACE rate because there are more complex lesions and so. So therefore, this is a nice the central figure showing that an individual endpoint. They also said that if you take a cases of the IVL like which were shown in the CAD the disrupt CAD3, actually the outcomes are still remain quite good with the current generation, the technique what we are using at present. So therefore, since its introduction February 2021, coronary IVL use has steadily increased, exceeding atherectomy use in Michigan by February 2022. Then contemporary use of IVL and atherectomy is generally associated with high rates of procedural success and low rate of complication. You saw it 2 to 3%, and that is what we have. Now, to answer which one is better, there are 4 randomized trials ongoing, and we are working on one ourselves, but these are the 4 randomized trials: roller coaster, sonar, decalcify, ISR wave. Roller coaster data were presented, which I showed there was no difference. In Euro PCR, it still had to come in the manuscript, was only abstract, but this is basically the 4 trials will answer this field that what is the appropriate strategy of the calcific lesion, although everybody had their algorithms, and we'll share our Mount Sinai algorithm next month because we have publication in this field. So let's complete our presentation for today. The key coronary intervention trials of TCT 2024 and the contemporary use of IVL in the PCI, routine use of OA versus balloon atherectomy, a balloon angioplasty in calcific lesion, 2 thumbs down. Okay, 3 thumbs down. All right. Aspirin-free strategy for low to intermediate risk free of 1 year post DES? Yes, because there is no reason, because they will cause less bleeding without changing any MACE. Then EES, DES over BVS or DCB, 2 thumbs up. And then lastly, paclitaxel versus sirolimus DCB for de novo or ISR lesions is equal, no difference. So the playing fields are equal. Then, since the introduction of IVL, contemporary management of calcific coronary lesions is changing, with IVL taking the center stage and resultant modest reduction in the atherectomy use. But still around, I would say both 5 and 5. I don't think even IVL is going to go more. I think it will remain there because many of these cases, and we learned 50% you will require atherectomy because your IVL will not go. Many calcific lesions and so. So like this case, maybe we would have modified with the balloon, but IVL would not have made turn in that circumflex. Now, some calcific complex coronary lesions will require both devices for optimal management, and that's the word we are using, rotatripsy. Overall, procedural success has improved significantly and procedural complications have declined. So great news for all. And I say that, and we are working in our data that has our complication of RA decreased since introduction of IVL. And to me, because why? Because you are not going for a second bar, you are going with a smaller bar. So we need to see, and we are working on that project, and you'll see it soon. Long-term impact of these strategy on lowering the TVF need to be determined by the future studies. That yes, it's good acutely, but are you decreasing their TVF and TLR and TVR at follow-up need to be seen. Just now, 3 quick questions. Eclipse trial comparing the use of orbital atherectomy versus balloon angioplasty for calcific coronary lesion showed the following except. Means what is wrong? Similar TVF at 1 year between 2 groups, similar mean MSA between 2 groups, trend towards higher stent thrombosis in OA versus BA group, lower slow flow incidence in OA versus BA group, and similar incidence of MI between 2 groups. Answer is slow flow was higher in the OA, 1.4 versus 0.4%. So D. Second, following statement is true for the 3-year results of the RIPS 6 trial comparing DES, BVS or DCB for ISR lesions. So what is the true statement? MACE outcomes are similar between 3 groups. TVR outcomes are similar between 3 groups. MACE outcomes after 1 year tended to be better with DCB versus BVS. Stent thrombosis similar between 3 groups, and both DES and BVS had comparable MACE outcome. Clearly, we know that from 1 to 3 year, the DCB did better compared to BVS. Then lastly, third question, following are the true statement about the contemporary trends and outcome of IVL PCI from the BMC2 registry except. That means the true statement except which one is not the true. Current IVL use is about 4 to 6% in US. Atherectomy use still remains higher than IVL. Perforation incidence is lower with IVL versus atherectomy. Lower slow flow incidence with IVL atherectomy, and procedural success is 80-90% with both IVL and atherectomy. Clearly, we know that now. Atherectomy use is lower than IVL at present in contemporary US practice. With that note, I present. Yeah. That's a wrong statement.
Incredible. Only you can do this at this speed and with this clarity now. Many disturbing issues, a couple of follow-up thoughts I have. First of all, I mean, this eclipse disaster, you were trying to put it very diplomatically and being a statesman, but it's a disaster. First of all, in today's time and age, anybody trying to do orbital comparing with the balloon angioplasty, excluding IVL and rotational ablation is really silly. And of course, now they've dug their own grave, so I don't know what will happen to that. It reminded me something like what happened with the after the manual aspiration for semi-came, that no routine use. Yeah. So, we'll have to see what happens with that. I thought the results of Assure DES were truly unsurprising. Yeah. Why should it be a surprise? 12 months later, you're going in for non-cardiac surgery. I think even the practical recommendation or what people are doing around the world is to take them off any antiplatelets and let them go for surgery. I thought the real amazing part was the BMC2, which is the real world analysis. I think this is probably not going to pan out. I think the number of atherectomy will simply go up because the amount of imaging will go up. And once I think, it becomes a class 1 indication to use either both of them, IVUS and OCT, I think we'll realize that there are far more number of calcified lesions which we don't appreciate, and for that sense I think it will go up. But and also as the last point, I don't think anybody would be surprised that BVS continues to struggle despite all efforts to push it back in.
And I will just add one more point, and this is a lot of people may not know. The IVL, there is a risk in terms of financial reimbursement for the institution. And this is people looks at the outside. Ambulatory IVL is not being paid. They may restart. They lost for almost 1 year now. So whatever you have done, ambulatory IVL, you put a $4.2 thousand of reimbursement, get zero. Outpatient ambulatory IVL disappeared. Second, in my opinion, and that is why, if you really deep down, and we have done the cost analysis, we have done the cost analysis of the IVL cases, complex IVL alone cases, or we've done the rotablation, complex cases of the rotablation. Because of the amount, because you still don't get 4,200. You don't get 4,200. You get about 3,500. You're still losing additional money, even in the inpatient. While in the atherectomy, it's okay because 1,800 to 2,000. So financial aspect, which I didn't want to touch onto it, is a very important. At the outset, everybody looks like a hero. I'm using this IVL, this calcific lesion, but go to your administrator. Right now, 2 other hospital people are coming. Top hospital, I cannot say the name. They want to come and understand why they are losing money with all these new devices. I'm not blaming only IVL, maybe other things also. So question is, they're coming to understand that what is the right way to take care of it. So just want to say to everyone that before you say that you are the master of IVL, which is a great device, no question, but its use has to be, even we have the pass-through code, the new device code is still not compensating for the full reimbursement of the device.
Anu, any final comments from you? All I can tell you is my entire message board is loaded with the compliments for you and the case very beautifully done.
My comment, I think I'm trying to teach people, if you're imaging, how to understand the imaging parameters and the decision making of which tool to use.
So my final question to you is, in retrospect, you think the strategy to go with 1.5 versus 1.25 Rota was the correct one?
I would have gone 1.5 in the circumflex and gone to the second lesion. But I mean, going back, original thought was we do a 175 bar from distal left main to LAD. That would not have done, because we saw the distal left main, which we will show next week, not next week, next month, the algorithm that we have created, how truly to use the algorithm in the calcific lesion. So that would not have helped either. Now going back to, would have IVL made the turn into the circumflex? Probably not. But there is a lot of teaching when I go outside, is that people are a believer. You can do a balloon dilation and then do Rota, balloon dilation and then do IVL. But these cases, you can't get a balloon down. So the the thought process of first do a balloon and then try to get any device down does not exist in these complex cases.
Yeah, no, I mean, to say not for Rota, but for the IVL, yes, 55% in the disrupt CAD, where you knew were not very, very calcific lesions. They were calcific, but not long, because remember, one of the region entry criteria of the disrupt CAD3 was you believe atherectomy is essential. So if you believe atherectomy essential, those cases were not enrolled. So just even then, they require 54% pre-dilatation. So I think IVL okay, but definitely we teach, we never do, I mean never kind of 99.99 that we'll not do a balloon dilatation before rotational atherectomy.
We never do.
Yeah.
Yeah.
Excellent.
Okay.
Samin, Anu, thank you so much to the fellows and the support staff. Outstanding job. To our viewers, thank you for making the session so interactive, and please answer those simple questions and claim the CME. We'll see you December 17th for our next transmission.